Good evening, friends, and welcome back to the Thursday clinics from CNS Hospital, Mumbai. Once again, we thank the Department of Pediatrics, CNS Hospital, and the authorities at CNS Hospital for allowing us to conduct and webcast these clinics. And we thank Alchem Alpha for an educational grant facilitating this webcast. Today is the last day of Pedicon, and a few students are there, so we may have less students. We're just waiting for 2-3 minutes for some students to come, and then we will start with the case presentation today. So though all our online friends and viewers, please bear with us for the next 2-3 minutes. Thank you.
Sure.
So we'll start with the case for today. The case is being presented by Dr. Shiv Prasad from CNS Hospital.
Good evening, everyone. Here we start with a case. Good evening, everyone. Here we start with a case. A 8-month-old girl, second by birth order, born out of non-consanguineous marriage, Jayaswar by community and Hindu by religion, hailing from Uttar Pradesh, an informant being mother, reliable with complaints of multiple episodes of paroxysmal event since 15 days and not accepting feed since 4 days. A child was apparently alright 15 days ago when mother noticed the child had one episode of paroxysmal event in the form of tightening and twisting movement of all four limbs with arching of back and turning neck to one side associated with excessive crying lasting for 1 minute, subsiding by its own, which is not associated with uprolling of eyes, not associated with deviation of mouth and frothing at angle of mouth, bowel bladder involvement or no post-ictal drowsiness. These episodes are 5 to 6 times a day. After that, frequency has increased to 20 to 25 times a day. Initially, child was accepting breastfeed, but since 4 days, child not accepting breast milk also. So parents started giving formula milk with water spoon feed, but child taking time to swallow and regurgitation present that time. For the above complaint, child was taken to multiple local private practitioners where they assume it to be abdominal colic and prescribe accordingly. Again, parents took child to higher center where child was giving anti-seizure medication for in view of convulsion, and where they have performed neuroimaging done which is abnormal and lumbar puncture also done. Then they refer to our center. On negative history, there is a history of lethargy with decreased oral intake present. There is no history of any cough, cold and increased respiratory activity, no history of any loose stool, recurrent vomiting or diarrhea. There is also no history of any jaundice, abdominal distension, no history of sleep disturbance also, and no history of fever, rash, no history of any COX or COX contact. Past history, there is no history of similar complaint in the past, no history of any other medical or surgical illness, no history of admission in the past, and no history of sibling death also. Antenatally, mother registered pregnancy at 4th month of gestation. Mother received TT injections and supplements. USG scans were done and were told to be normal. There is no history of fever or with rash or bleeding or leaking pervaginal. Birth history full term LSCS. Birth weight of 3 kg. Baby cried immediately after birth, where they receive birth vaccine, and there is no history of any NICU stay and discharge on day of life 2. Immunization history, immunized till date according to National Immunization Schedule. Developmental history on gross motor, child roll over at 7 months of age, then no roll over since 15 days, no seat with supports also. In fine motor, unidextrous approach was there, mouthing present, on language monosyllabus, and in socially child was laugh loud. These all milestones achieve all appropriate milestone in all 4 domains. Now not able to do any of these. Dietary history exclusively breastfeed till 6 months of age, then started complementary feeding at 6 months of age with dal, rice and chapati mixed in a dal. Family history, there is no significant family history. There is no any unexplained death in a family. This is a pedigree chart. So socioeconomic history.
Go back to the first. Okay, come to the description of your thing. Okay. So, what do you all think? What is your impression about the first event? What will be your thoughts?
It was an unprovoked paroxysmal event, like without any fever. So
So very good. First thing you said is that it was an unprovoked event. So that is one thing that you noticed. Now what else?
So since there is no fever, so and the child is less than 1 year old, we would think of something metabolic.
No. First we have to decide what is this event, and then we have to go deeper as to what it signifies or what is its cause or why could it be or whatever. So first let's focus on what is the event. So what is it? Is it a seizure?
Sir, the history of tightening, so possibility of seizure is to be kept in mind, but there's also twisting movement. So dystonia or other movement disorders, we'll have to keep in mind.
Okay, very good.
Why not seizure? Give reasons why you said it's not a seizure. Seizures are far more common than rest of this, right? You're right, but justify your statement.
Sir, there's a generalized involvement here, but
Seizure
no,
is generalized.
but no uprolling or deviation or
may not be
any
noticed.
altered consciousness.
We don't know whether there is loss of consciousness or no. You have written post-ictal, but whether there was ictal at all.
So to decide whether it's a seizure or no, what all do you need? And then from that, what is easy and what is not easy to make out? So what all do you need to decide whether it's a seizure?
So during the episode, whether there was awareness or not. So in this case, the child was crying during this episode or not, and
Okay.
whether there was spontaneous passage of urine or not.
No, so spontaneous passage of urine is not a sine qua non of seizure. No, some may do it, some may not. So that's not important. You're right. Whether the patient or the child is aware during the seizure. Now, in a 8-month-old, how will you decide whether the child is aware or not? In such a small child. So what questions will you try to ask the mother?
So during the time of the event when the parents are trying to interact with the child, is he corresponding to the mother's commands or?
Okay. So that is one. Anything else?
See, you're right, but at that moment when sudden paroxysmal event occurs, mother may not have that feeling of finding out whether the child responds. You're right, but that's not often so. Anything that mother may have observed, if you ask, she might say, yes, I have observed, which will tell you it's not a seizure. So in a seizure, the eyes are open or closed? Open.
And if he's
So,
blinking or no. And if the child is blinking at the time of the event or no, we can ask.
So is it just blinking or you want, means, so even you are blinking and I am blinking. So is it seizure or not seizure?
Means in
So you have to qualify that blinking. You want blinking, you don't want blinking.
in a seizure, usually the eyes will be open and child will not be blinking, like staring.
Okay.
Look.
So that is staring at one point and not blinking. On the other hand, can repetitive blinking be a seizure? It can be repetitive twitching of the eyes. So both are possible.
now here he has said not associated with uprolling of eyes, so which means that the eyes were open. Otherwise, how would he know there was no uprolling of eyes? Okay. So here is a situation where eyes were open. Apparently, that's the history. Otherwise, she would say, I don't know. Or eyes was closed.
Have you asked specifically whether the eyes were open or no? Because she has said there was no upper ceiling of, how do you know? The eyes were closed. We don't know whether. So it's important to ask specifically. Was that inquiry made?
We also have a video of that.
Yeah, you have a video, but did you ask in the history? Video we'll see, but you have also seen the video, but what is the... Because in a child like this, there are not too many things to decide whether it's a seizure or not a seizure. Now just twisting of the movement and becoming stiff could be a part of an involuntary movement. The child could have just as twisting and maybe as part of involuntary movement. Though twice on both the sides, we don't know, but if the both sides are involved, there has to be a loss of consciousness. So any more history, was the child responding, eyes open? If they were open, whether deviated?
So see, he must have asked, was there an uprolling of eyes? She would have said no. But to me, uprolling of eyes means eyes were open. Okay. But casually asked, did you find any uprolling of eyes? She says it was closed, no? So she said no. So remember these fine points. What question you ask and what parents understand is very important here. Suppose we are not sure at the end of the story.
So before we go, so always at such crucial junctures, you should ask open questions and not closed questions. So don't ask eyes were uprolling or not. Ask how were the eyes.
How were the eyes?
Let them describe. Okay? So that increases the genuinity of the thing.
Now look at the next. 5-6 times a day. What happened in between? We have not known. If there was a seizure, what would have happened in between? And if this was an abnormal movement, what could have happened in between?
So he has mentioned no postictal drowsiness.
Yes, that's fine.
So no, so what we want to know is that, so after this movement stopped, did you ask, okay, what happened the next second?
The child was active with
not
Immediately,
alert.
within 1 or 2
Yeah, alert.
seconds.
Child was alert. No sooner the so-called event stopped, the child was alert. How did the mother find out, or how did you find out the child was alert?
On history only, sir.
What did you ask?
I asked after the twisting movement whether child had lost.
Just speak on the mic.
So if the child was sleeping or drowsy after the episode, that could indicate the post-ictal drowsiness. Second thing, if the child is interacting with the mother, can show that the child is extremely okay. If he's interacting and cooing.
So what interaction would you expect in the child 8 months?
When you talk back, the child does talk back, like responds back.
Yeah,
to you.
response, look at the mother meaningfully, at least respond, if not by anything, or the mother can make out that the child was alert. If the child was alert, it favors what?
So I think what we have learnt is every time there is a seizure or seizure equivalent, you need to know what was the immediate preceding period of seizure, what was during seizure, and what was immediately post-seizure. All three are important. For example, there could have been a focal seizure with generalization. If you did not ask how did it start, you would have missed the focality. So small little things make sense. What do you make out of this crying for a minute? Okay, this first episode associated with excessive crying lasting for a minute. Okay. So does seizure end up with a crying? Does seizure begin with crying?
Seizure
or does
can
seizure
begin-
accompanied with crying?
Seizure can begin with a cry, like ictal cry.
Very good. So this ended up with crying. Okay, so another issue possibly looks little different. But why is he crying? And rightly he had said in the next slide, here only, they said it's an abdominal colic. Yeah, because he was crying, no? So why was he crying then? Yes.
Could it be some aura, like sometimes a seizure may be preceded because the child is.
But she
so-
said it is aura is before the event.
Okay.
Okay, she said that it is before the
Again,
event.
again, the point is, first, though we don't know here for sure whether this crying was before the event, in the whole event for 1 minute,
Yeah.
or what.
But lasting for a minute. So I imagine that it must have been following immediately or during. We imagine that. But this is important to get to so many details, right? Okay.
Means not every time it is very easy to assume that given event is seizure. These fine points are important. Even in an obvious seizure. But when you keep on asking that, then it happens. Otherwise, you
No.
tend to forget.
Incidentally, at 8 months, frothing at angle of mouth and bowel bladder, and this is not easy and is not mandatory also. So if you get it, it's fine. Now discuss both. Suppose it was a seizure, what are your thoughts next? And suppose it is not a seizure, what are your thoughts?
And in a healthy, normal child prior to the event.
So suppose it's a seizure. Start, what are your thoughts? You said unprovoked, so we keep that in mind. So what are your thoughts? When you get an unprovoked seizure at 8 months, what should you start thinking?
What will happen after the seizure?
See, seizure is typically of three types. Okay, you know all these three types, right? What are the three types of seizures? I'm not asking whether it was generalized, focal, etc. Okay. One is acute symptomatic. Okay. Other is remote symptomatic. And the third is idiopathic. Okay. Which is this? Is it acute symptomatic?
Because
Why not?
Why not?
the child is immediately okay after the seizure.
No.
There's no
Acute symptomatic means what?
like
Give an example.
hypoglycemia, hyponatremia.
Okay, hypocalcemia,
Hypocalcemia.
hypoglycemia, whatever.
Inborn error of
Meningitis,
metabolism. Not all
encephalitis.
come right away. These are all acute symptomatic. Okay. So we are not sure whether it was acute symptomatic. All that you know is that child was neurologically, cognitive wise normal. So you have ruled that out. But acute onset metabolic disorder stand.
Yeah, means the point is that acute symptomatic can, so suppose at that point he became hypoglycemic for the first time. How would we know? This was the first manifestation of that hypoglycemia.
Okay.
He wouldn't be all right later, no? Like immediately post the seizure, the child wouldn't be all right.
So not in all acute symptoms. In hypoglycemia he may not be all right. In hypocalcemia he'll be typically all right. Right?
So now we keep in mind the metabolic. Can we rule out a metabolic? Or what type of metabolic possibly we can rule out? For example, you said hypoglycemia. Could it be hypoglycemic?
No.
Why not?
Because no other symptoms.
What
also.
other symptoms? You want a
He's
seizure?
he's apparently okay after the episode, immediately after the short-lasting episode. So would have been drowsy if it was hypoglycemic.
Right. Because
Increase in the frequency of the episodes, and the history is also since 15 days. So it is unlikely to be hypoglycemia for that long.
would hypoglycemic seizure stop by nature before you intervene? Yes.
Not like.
Why should nature be able to stop the seizure?
Do you know any hypoglycemic seizure which may stop on its own? I saw a child who at 4 a.m. in the morning was found to be limp, sweating. And then we did everything and then he was relatively all right within half an hour or so. This was a normal baby but low birth weight.
Fatty acid oxidation defects if you give dextrose. Well then.
He was not given dextrose.
Okay.
He did become limp, sweated, but then later on, by the time he was brought to me, he had recovered. Any hypoglycemia can get self-correct. Have you heard of ketotic hypoglycemia or ketogenic hypoglycemia? Will they always require treatment or you will get self-corrected? They may get self-corrected.
No, so see, this is very important to think. Does a hypocalcemic seizure just go on and on and on till you give calcium? So it stops, no? So why does it stop? Because the body corrects that and obviates the hypocalcemia. So body will always try to correct metabolic problems. Sir is asking how? How does it do it?
Compensatory mechanisms.
So what? Give an example. So hypoglycemia is corrected by what compensatory mechanism?
It's a counter-regulatory hormones.
Very good. Counter-regulatory hormones. So there is a gush of adrenaline and glucagon and all those, and they will try to bring up the glucose and try to correct the situation.
But the only point about all this is very temporary in hypoglycemia. For example, if you have some glycogen there, it won't last for more than a few hours. Thereafter you have no reserves. Then you will have to get some more glucose from other sources, which are not so strong sources. Therefore, if this happens again and again, you will have to intervene. Once in a while it will get corrected, but not. Same is about hypocalcemia. After all, when parathyroid can work, but there has to be a calcium available in your bones to be shifted onto the tissues. So, till the supply is there, okay, the mechanism, hypoglycemia, the mechanisms are not so strong as hypocalcemia is. Okay, because the glucose is not stored for a long time in large amount. Okay, the brain needs all the time. Calcium is stored in the bone. So I think to begin with, it is unlikely hypoglycemia, and initially there were only 5-6 times, then its frequency is increasing. But which means initially after 5-6 times the things were not so bad. Therefore somebody called it an abdominal colic and sent him home. That means child was apparently all right. Okay. So we take a note of all that.
So, post-ictal is also important. He became all right and immediately his responses were good. That is less likely to occur in seizure, and every time this has been. Some repeated seizure, some post-ictal phenomenon is expected. Usually there should be something even earlier, but at least post-ictal you should get.
So we said this could be a seizure because on the history we have not got exactly all that we wanted. So we are discussing, could it be seizure? If so, it could be acute symptomatic. Could it be remote symptomatic? What do you think? I said acute symptomatic, remote symptomatic and idiopathic. We said yes, it could be acute symptomatic. Could it be remote symptomatic? What is remote symptomatic?
Infections like meningoencephalitis.
What is the concept? Remote symptomatic. Anybody? Pass on the mic.
Previous.
In perinatal birth events or initial 1 to 2 months infancy, there is some insult, neurological insult. Then it will go again with gliosis and some changes in brain, and it will lead to seizures later on.
Very good. So what you are trying to say is that there is a pre-existing damage. Okay, pre-existing, because see, you use a remote, no? There is a pre-existing program already on, therefore it comes up. Okay, if this child has been all right as per the history, then it's unlikely a remote symptomatic. That's out. Could it be idiopathic? Yes? You know, we have repeated this. Idiopathic is, what is idiopathic? Patient is pathetic and the doctor is idiot. So could this be idiopathic? We are not all idiots, right? So we must answer correctly.
So can it be the beginning of an epilepsy?
Yes?
Yes.
Epilepsy, idiopathic, never begins at this age. Think about it only beyond 5 years of age. So this child is 8 months old. Don't think about it largely. Yes? So it has to be acute symptomatic. Okay. Now what other than metabolic could be an acute symptomatic? It's not infection. Okay. Metabolic we said. What other probable causes of acute symptomatic where the symptom is seizure only? No other symptoms.
Vascular event, but
All
such
right.
a young child, very young.
Very good. So you are thinking about some congenital malformations maybe? All right. In which case, generally there would have been a focality. Okay, this look is generalized. So final thing is it's acute symptomatic.
Now that's if it is a seizure.
Yeah.
Suppose if it's not
Not
a seizure.
Now
then
we'll
what do you
discuss
think?
the other things.
What do you think of this description? You mentioned earlier that it is dystonia. So it represents what?
Basal ganglia involvement.
Correct. So now what could be the reasons for this dystonic episode to come up at 8 months for the first time?
Talk something, doesn't matter.
Viral infection.
So just now is there an infection?
We said no infection and no past story.
So if I ask you common causes of dystonia, what are they?
Hypoxic
Hypoxic ischemic encephalopathy, which here the history is clear. Next. Kernicterus. Here the history is not there of any neonatal jaundice.
encephalitis.
Encephalitis just now. History is not like that. Then what else? Any drugs? So drug induced, but you are not given any
drugs
drug.
cause dystonia?
Metoclopramide, Perinom.
Good. So anti-vomiting, but this has no story of vomiting. So not. Majority of the time what starts acutely, we have said earlier, is metabolic, immunological, okay, traumatic, all right, vascular. Now vascular are localized. Trauma is out. Immunological is inflammatory. Therefore, it must be metabolic. And almost all neurodegenerative disorders are metabolic in origin. Okay, yes, genetics also are there, but here there is no genetic story. So final impression, if it's seizure or not seizure, yes. But could it be any other cause of dystonia?
So there are many hereditary dystonias, lots of genetic dystonias. Some of them are DOPA responsive, as you know,
Yes.
and they can start at various ages. So we keep those in mind at this stage if it is a dystonia and not a seizure, right?
That's right.
Sudden starting of any involuntary movement from nowhere is less likely. There should be something like that. Initially there were some movements, etc. All of a sudden this is an abrupt onset. So between the two, though we are not sure, maybe we favor a seizure disorder more than an involuntary movement.
Now this part about initially accepting breastfeed, but since 4 days not accepting, again we need details of this. So not accepting means what? Child is not crying for a feed, or child is not able to suck, or what, and what is the sensorium of the child? That is important in this phase, these 4 days. So what is the answer? What do you think? What history did you get?
If you don't know, doesn't matter. We are here only to know how better we could be asking the history also. Doesn't matter, because many times maybe you're so busy, you're asking history quickly, but this is only to train you how history is so important. Far more important than anything else. Okay, that's why we are. If you don't know, doesn't matter. Okay.
So, but let's discuss this. So typically when you are asked that 8-month-old is not accepting feeds, what is your thought process?
Is he anorexic? He has no appetite, no? Mother says he is not taking. He has no appetite. Okay. Or he wants to take, but he has something in the mouth, ulcers he cannot take. Okay. So how do you make out all this in a history?
You all always say, no, newborn not feeding and sepsis. So what is that situation? Give an exact description of that versus what sir said, somebody has hand, foot and mouth disease and not feeding. What is the difference? Mike.
Means if the child is like septic, so the child will be lethargic and will have refusal to feed. Whereas if there is some local cause, then the child will be hungry, wanting to feed, but unable to feed due to the local cause.
Excellent.
But the sensorium will be
Very
good.
So he was crying, telling us that he was hungry, and when put to the breast for one reason or the other, either he made efforts to suck or he didn't make effort to suck, then that will tell you whether it's going to be painful or difficult in swallowing. All these possibilities are there. In painful, he'll put his mouth to the breast, but then he will retract. In swallowing difficulty, he may swallow, but then it may come out or it may have nasal regurgitation. That means there is desire to feed, he's taking it, but unable to swallow it down. So all points will tell you exactly. So how do you explain it? फिर क्या हुआ? पहले दूध दिया तो रोता था? Was he hungry at all? Yes, he was hungry. How do you know he was hungry? Because he was crying. Then when you put to the breast, what happened? Did he accept or he didn't touch at all? When he started taking, did he swallow? Did he make proper sucking movement like earlier? And then it came out through the nose. So you know exactly where the problem is.
So here then he's saying that Vati spoon feeds, it was swallowing was taking time to swallow and regurgitation. So what are your thoughts? What could be the 2-3 possibilities and how will you further tease them out? So when it is taking time to swallow in a Vati spoon feed, what could it be?
He may be lethargic and not swallowing.
Okay, so the baby is very lethargic and that's why not swallowing. So what question will you ask?
Does he always drowsy or...
Correct. So what is the sensorium or the behavior of the child all the time, feeding or non-feeding, versus somebody who has a palsy here and therefore has difficulty in swallowing? What question will you ask?
Someone who has a palsy will always be hungry, irritable, crying for feed.
So it depends, it is variable. Obviously these bulbar, pseudobulbar palsies all originate from the CNS lesion. So there could be affection of sensorium as well, right? But yeah, so you want to know what is the sensorium of the baby, and is while this swallowing is there, and he's saying regurgitation is also present, right?
Yeah, we need to know, did he demand at all? If he demanded, that means he was hungry. He never demanded, the mother was putting him to the breast. Then we don't know whether he had a pain, he was refusal, so it was higher or what exactly. And if he made an effort, he was demanding, but he was not sucking properly, maybe pain. And he was making effort and it was regurgitating, then it is swallowing mechanism defect. So every step is important.
Could it be GARD?
That is usually after taking the feed, the child will then have an issue. Not in taking the feed, post feeding immediately the child will have feed, but not swallowing won't.
This is about the swallowing, but he said there is arching of back and all. So sir is asking whether that is GERD.
And this typical Sandefur's, abnormal movements, okay, arching of back, you are calling it a dystonia. Okay.
Increasing frequency of the episodes not associated with meal timings.
So
Usually
tell me one good reason that it is not so.
growth, weight gain will also be affected if it's
Acute onset at 8 months of age. How can one fine day the GRD starts with a bang? Okay. So largely not, but because of arching of back.
And then these GERD children are irritable throughout. Because what is GERD? It is dyspepsia. So it is hurting him at a low grade continuously.
And
So
what is the difference between GER and GRD?
GR does not cause weight loss and...
How do we know clinically? Both are reflux.
So GR kids are happy spitters, so they just regurge out, but they are otherwise gaining weight. And GERD would not be gaining weight and would be irritable throughout.
Very good. So D is deceased child. Okay. Is there a VURD?
There are grades
GR
of
and
VUR.
GRD. VUR and VURD or no VURD? They are not deceased.
There are grades of VUR, so the mostly will get okay on its own.
This is just to stimulate your grey cell because you have far many more than me. So I am just trying to stimulate you.
So do you treat all grades of VUR?
They self-resolve as the child grows usually. So
VUR is not normal. Whether you want to ignore it, whether you want to monitor it, do nothing about it or do everything. But it could be never normal, right? Whereas GR is normal also. You said happy spitter. So therefore GRD. Anyway, that's fine.
Okay, so this is our initial thoughts on this. So first take the details of that event, then seizure or no seizure, then if seizure, what is it? If no seizure, what is it?
And many inborn error of metabolism also may affect the basal ganglia. Okay, especially the multiple carboxylase deficiency, biotinase deficiency. Oh, peripheral nerves may be involved, skin may be involved. So this could be a beginning of some neurometabolic disorder. We might see what is happening thereafter, right?
Go on. नहीं और हिस्ट्री में I wanted to just focus on your negative history. So cough, cold, increased respiratory activity. Why? Speak in the mic. We are just learning, so don't worry. We are very happy that you being so junior also have come forward to present. So we are very happy about it, okay? So don't worry. This is just a place to learn.
To rule out any chronic respiratory disease like...
Correct, but how is it related to the chief complaints here? What thoughts did you have?
If there is cough or cold, there is a hypoxia maybe. Due to hypoxia, there could be seizures.
So see, hypoxia usually is in a acute severe respiratory illness, correct? So this is, and in that case the patient will come with that complaint, no, that my child is breathless. and after that is doing all this. You getting what so we are just learning. Okay, next, history of loose stools, recurrent vomiting, diarrhea. It is related. You're not wrong in this. I'm just asking you why.
Any thoughts on that?
So repeated loose stools or vomiting can cause electrolyte imbalance, and thus the child can throw seizures.
Okay, what did we analyze the first event to be? Our first DD is, what is our first DD? Metabolic. Metabolic disorders can have repeated vomiting, no? So it is relevant. Okay? Okay.
Though often a child who is normal and starts with something, seizure or no seizure, vomiting is often an aggravating factor at the onset. And most of these conditions could start just as a trigger to a neurometabolic disorder, but often not a strong accompaniment. That is one. And we have said this again and again, that negative history should be such that it is so minor events that parents forget to tell you. Okay. If there is a jaundice, they would tell you that. We are not asking for past history, we are asking for present history. So, which parents will forget to tell you, oh, there was a lot of cough, breathlessness, jaundice, diarrhea. No, they would come out first with that. So, negative history should be such that is relevant to your chief complaint, but often minor enough according to parents not to even disclose voluntarily. But when asked, they would say yes. Like appetite. She's not worried about appetite, she's worried about those moments. But you would ask, what about appetite? Yes. Oh, it's very poor. Now that makes you know. So don't ask too many questions about no history. No history should be short and very relevant, right?
And also then, so by relevant we also mean now no history of sleep disturbance. So it is tricky at 8 months that then again the examiner wants to pull your leg, they'll ask what sleep disturbance, then you should be ready with what you can make out at 8 months.
In examination you would have said no history of any significant accompanying symptoms. Now we ask what is significant? Okay, yes, you have the whole list if you like. But why say this, right? Similarly, when you say about the maternal history, antenatal history, you say no significant abnormality in the mother. Okay, let him ask, no toxemia, no diabetes. Now we will find out which one you have not mentioned. Okay, so group that and that becomes easy, becomes short. In examination you have a small time. You don't have a big time to say all these diseases were not there. Say none of them. Okay.
And you could have talked of history of other neurological area involvement anatomically.
That's right.
So motor area, so no history of any movement deficit, no history suggestive of any cranial nerve, saying that other anatomical areas are involved, besides basal ganglia which we are already discussing.
Like you could have said no crossing of legs. After all, yes. Okay, you could have said no posture like hypotonic. Yes. So something of that kind. Okay.
Okay. Just for learning. Okay, go on. Fine. So now sibling death is very important and fine. Okay, go on.
Go ahead.
Milestones.
Milestones, yeah. Now stop here. Okay. So now tell us, what do you think of these milestones?
Roll over at 7 months. You think it's okay?
Do you start with 7 months or you start early? So what would you start with? Concentrate on gross motor.
First question is, rollover achieved at 7 months is normal or late?
Late. It's a
What age do you want?
5 month it is.
So this is late.
So
Okay.
it's a bit late. Of course, parents may have said 7. We take a note of that. Okay. No sit with support. 8 months is okay?
Usually comes by 6 months sitting with support.
Yeah,
So
and
when
8
does-
months, in
months
fact,
is-
you may want independent
Sit-
sitting, right?
So when does sitting start?
At 6 months, 5 to 6 months sitting with support in
Very
the
good.
tripod position.
How does a baby sit at 5, 6 months? You're good.
Tripod position.
Tripod, very good. And then you know.
But
the
how does he
lateral
come to
propping,
sitting position?
No, so at 5 to
Rolls
6
over.
months from supine, can the baby come up to sitting?
No, he rolls
Then-
over to the side and
He's made to sit. When he's made to sit at 6 months, he can sit with support. If pushed, he will fall. At 8 months, his back is straighter and he has developed what is known as propping self-defense mechanism. So if you push, he will support himself. But he has to come to sitting position, on that he cannot do without it.
good. So rolling over looks to be a little delayed, right? What about fine motor?
So when does unidextrous approach come? So again, for exams, it's not just okay to say that this child has a unidextrous approach which is now lost. It's also important, when did he achieve it? At what age? Right? So what age do you want a unidextrous approach?
6 months,
Okay. And mouthing at what age?
4 to 5 months
Yeah, so
actually.
3
there-
months, even earlier.
So
Earlier,
there
4
has to be a
months.
chronology. You ask the earlier milestones first and the later milestones later. So you have asked for the unidextrous approach will come a little later. Mouthing comes very early.
So there are two ways or two concepts here. So if your judgment is that this child is delayed, then you start with 2 months milestone, 3 months milestone, and give an idea whether they are all delayed equally or they are getting better with time or they are getting worse with time. If your child is normal, then you give the last achieved correct milestone and that's it. So if you say this child was sitting at 8 months, it is obvious that before that rollover and this and that was normal. So don't waste time in rollover at 4 months and sitting at 8 months, right? So different ways of presenting.
But do all milestones go in the same order? Can you start holding head much before rolling over? Normally, yes, isn't it? Now, how early can you start holding head?
3 to 4 months.
So suppose the mother says right from 1 month only, our baby is super.
Pathologic.
It's pathologic.
Hypertonia of the neck
What
muscle.
kind of hypertonia?
Extensor muscles.
Extensor hypertonia.
Very good, right? Okay. Then language. So 8 months, what do you want?
Monosyllables is okay? You want bisyllables?
Bisyllable by 8 months.
Okay.
All right, not too bad. Okay.
And social?
Laughing aloud, what age?
What is the difference between laugh and smile? It's the same thing, no? Different description.
In class, smiling is allowed, laughing is not.
Is
You
there
say,
a
no,
difference
he
between smile and
laughed
laugh?
at me is different than he smiled at me, no? What is the difference?
In smiling means it can be just a simple spontaneous smile or a social smile, but in laugh he's trying to vocalize. So
So at what age?
eventually-
How will you ask the mother?
Means we'll ask her if he's just looking at you and smiling or if he's actually making a sound and
Yeah.
Very good.
laughing.
So laugh involves a sound also, right?
You can even show her that. And what age?
Laughing at what age?
4
to-
months.
4 months, yeah. Okay. Huh? So good. So now in this baby, what would you expect at 8 months, social development? Means he is laughing loud, the last thing in social development you expect at 8 months?
What is a must at 8 months?
Social.
Stranger anxiety. Will
Okay, stranger anxiety.
Sometimes variable.
What else? So does stranger anxiety depend on something? Okay, so I'll give you just one example. There's a nuclear family, mother, father and child, and there is a joint family with 17 members. Who will develop stranger anxiety first? Nuclear family. Very good. Okay. So because there are so many people, that child may develop stranger anxiety a little later, maybe 9 months, maybe 10 months. What else at 8 months? More important, social we are talking of.
Just give the mic.
Waves bye-bye comes at around
At 10 months.
9.
Yeah,
So
little
not
later.
abnormal if not there at 8 months. So what is this 8-month-old understanding?
Cognitive.
Does he know that he is a boy or a girl? So what does he know? He knows who he is. So responds when called by his name. Okay.
And
Whatever
how will
his
you-
name, pet
how will
name,
you call
real
by
name.
I called him by name. Ashish, he looked at. Then I called him ABC. He looked at me. Then I said XYZ. He looked at me. So you need to know whether he's responding to sound or is responding to his name. And I stand behind and then call him. What is a good milestone at 8 months? Cognitive. Child is CP somewhat. So all his gross motor milestones, etc. You cannot judge his development from that. Everybody does that. Have you heard of peekaboo? Okay, it comes at about 8 months, and many children, almost all of them enjoy it at 8 months, even a little earlier, and you don't require any physical or gross motor milestones for that. So do ask for cognitive, knows his name. These are important.
So now tell us, is he normal or delayed?
Delayed. Delayed, and there is no rollover since 15 days. So
No, forget the recent development.
Delayed.
Even before the recent
Prior to-
development,
yes, he's been delayed throughout.
he is a bit delayed. So
So the bit delay could be environmental, okay, non-pathological. We keep all that in mind because it's not a severe delay.
Yeah.
Okay, but you are right. Looks very little. For example, if he's a fat so, he could have a little problem on gross motor. Okay, so but you are right. Things are not totally normal. Maybe within normal limits at the lower end, or maybe even early pathological. So we keep that in mind. Okay, go ahead. Go ahead.
okay. I think rest nothing else in the history. So at the end of the history, what is your provisional diagnosis?
8-month-old girl, second by birth order, who is brought with a chief compass of multiple paroxysmal episodes and not accepting feed with lethargy in child who is developmentally slightly delay, who lost since onset of symptoms. My differential diagnosis will be status dystonia, which is secondary to inborn error of metabolism and any infectious etiology like meningitis or any chronic infective etiology like Cox.
Meningitis now or meningitis in the past?
Now.
Okay, so all of you want to discuss these DDs and rearrange the order or something like that?
I think when we are talking about differential diagnosis, don't give me possibilities, give me probabilities. Possible, anything is possible in medicine. Okay, you could say infection may be without fever, without any symptom, yes. But that is possible, but what is probable? Infections are out. Okay, probably not. Now if you say, could it be possible? Yes, TB could be silent, but which TB present like this? Okay, so not at all possible. So which of these are likely?
So,
The last two seems to be
yeah.
out.
So inborn error of metabolism definitely stands. I'm not very sure, is status dystonia a term?
No.
I don't, is it? You have read somewhere?
Not heard of it.
Yeah, we've not
Well,
heard of.
possibly he's calling status because it's repetitive, etc., but not really so. We call it dystonia, yes, of whatever origin, and again we go back to be a neurometabolic disorder. So finally, whatever it is, because when you say status dystonia, it is not a diagnosis. It is the description of what is happening. But when you say inborn neurovedism, it's an etiology. So from that point of view, we stay with that, right?
Maybe I would summarize it like that, that this child may have had an episode of involuntary movement like dystonia, or it could be seizures, because we are still not settled that issue. If it is seizure and it is of a sudden onset, if this, I favor a metabolic disorder as the first cause of it. To support it, there may be slight delay in the development of the particular child. Something which has occurred from nowhere suddenly and has persisted and has also given rise to lot of other things, like this child has achieved milestones. So I would favor that. And then seizure is a stronger possibility. Something which was all right and suddenly dystonia occurring from nowhere in a child is less likely. One has not. Initially there may be some involuntary movement somewhere, and then they are progressive, etc. If it is dystonia, then again I would have to entertain the diagnosis of a metabolic disorder. But the abrupt onset and the past which is related,
Sir, hold like this.
and the past which was normal, I would keep that down. So first is a seizure, metabolic. Less likely is dystonia or an involuntary movement. If that is so, also it is more likely to be metabolic.
And I think the typical dopa responsive dystonia doesn't start all over. It starts focally, and then goes on spreading everywhere. If this started all of a sudden, then this is unlikely a dopa responsive dystonia. But the message is, in every dystonia, dopa responsive dystonia needs to be ruled out, because that's treatable dystonia. Otherwise, it could be difficult to treat or not so easy to treat. So, this is unlikely a dopa responsive dystonia.
Okay, we'll just quickly go on to examination since he has brought the word status. What is your concept of status epilepticus? Could this be status epilepticus if this is a seizure?
No, usually status will have loss of consciousness, which is lasting, if it is a generalized, more than 5 minutes. Either 2 episodes with no regaining consciousness between the episode, or 1 long lasting episode with loss of consciousness.
Yeah, so
there's
he's
no
saying
loss.
that last 4 days he is not feeding and all that, is lethargic. So he could be altered for last 4 days, no?
But there's no loss of consciousness. Immediately post that the child is crying, post the episode, like he's mentioned. Could be lethargic, but no loss of consciousness.
Right,
Good.
right. Yeah, good. Okay, go on.
On examination, child is lying in supine position with bed up to 30 degrees elevation. Childs appear irritable, with febrile, with heart rate of 140 minute, which is regular rhythm with good volume, no radio-radial or radio-femoral delay. Respiratory rate of 40 per minute, with peripheral pulses were well filled and central pulses also well filled. Extremities were warm and CRT was less than 3 seconds on SpO2 of 99 on room air. On head-to-toe examination, a child has a frontal bossing with a depressed nasal bridge and some pallor, with upper and lower limb tightening and twisting movement with arching posture, and on genital examination there diaper rash also present. Anthropometrically he is a normal.
Okay, 1 minute, go back. Any comments? Everything is okay?
Head circumference also normal between median to +1 standard deviation. But we have to, by the Dines formula, we have to check.
So check. 68 divided by 2, 34 plus 9.5.
43.5 plus 2.5, so all is fine.
It is normal.
Yeah.
Is it important? What were you expecting? Microcephaly, no? Then 45 is not microcephaly anyway. So were you expecting microcephaly? Neurometabolic disorder.
So you have to look out for macrocephaly also.
Why not microcephaly? Micro is far more common in neurometabolic disorder, isn't it? Tell me one strong reason why it is not microcephaly we are expecting at all. When do you expect microcephaly in a delayed child?
So we'll expect microcephaly in static encephalopathies like cerebral palsy, and your child had been feeding well, growing well, and initially the milestones were proper. I mean,
Yeah, so can you put it in a better way? You are right.
Remote symptomatic, we'll expect microcephaly.
With
But
microcephaly, there is likely to be onset of the problem at what age?
perinatal.
So
Perinatal.
antenatal, perinatal, not at 8 months.
And then you would
So we
have
don't
no
expect
abnormal
microcephaly.
milestone, no normal milestones all this time.
But do neurometabolic disorders have macrocephaly?
White matter disorders
Why?
can have macrocephaly.
So there are, of course,
Some where you get
Tay-Sachs, okay, Canavans, Alexander, okay, these are all macrocephalic. So this is not macrocephaly as we can make out. Yeah.
On systemic examination, the CNS-wise child is irritable with facial asymmetry during cry, with left nasolabial fold more prominent. No other focal deficit with pupils were bilaterally equal, reacted to light. Tone was hypertonia in all four limbs, with power more than 3/5 in all four limbs. Reflexes were bilaterally knee and ankle were brisk with bilateral biceps, triceps, and supinator were 2+. There is no any sensory system involvement with no cerebral or meningeal signs were present. On per-abdomen examination, the inspection, the abdomen which is globular, umbilicus inverted in midline, no scar, sinus, or no distended veins. On palpation, the abdomen was soft, which is non-tender, liver of 1 centimeter, which is soft, spleen not palpable. On percussion, there is no any hosh dullness, no fluid thrill. On auscultation, normal bowel sound were present. The system are not associated with the complaint.
So go to the neurological system exam. What is your conclusion?
So what is the interpretation of all this neurological examination? You want to give us the interpretation? Which system seems to be affected within the neurological system?
Motor system.
Very good. Motor system. So what is involved in motor system? What all is involved?
Pyramidal tracts.
Very good. So pyramidal tracts involved, then
Extrapyramidal tracts. Extrapyramidal
extra pyramidal involvement also. Okay. Then what else is there in neurology? Rest seems to be okay, right, in terms of these findings. So no cranial nerves.
Left nasofacial fold prominent.
Yes.
Facial asymmetry during cry.
on presentation, but now the child has no any such a history.
Is there any condition where there is facial asymmetry on cry, but there is no neurological disease? She knows it.
Depressor angular oris.
Very good. Depressor of angular oris muscle. And how would you diagnose that?
Only while
The
crying.
upper labial folds are normal, only the angle does not go down. Because depressor angular oris muscles is absent. Okay? Is it important to diagnose?
Yes, there's no, it just requires reassurance actually. No.
One is reassurance, and sometimes subtle things give you abnormal clues. This could be abnormal. For example, accessory nipples can be a marker for a congenital heart disease. Similarly, depressor angular oris muscles, you look out for subtle signs here and there.
How do you rule out that it is not a seven nerve involvement? Now, you said something, you have given the right answer. But tell me, why not a genuine seven nerve involvement? Because then the whole story and etiology might change. We are not expecting a localized cranial nerve palsy in a neurometabolic disorder.
it is UMN 7th nerve. He would have other signs, brisk reflexes, extensor, plantars. It would have all the
So
findings
now
actually.
to differentiate what you said rightly, it could be congenital. Okay. What are the points on examination which will convince you that this is not a 7-nerve palsy? I'll give you an example. If my 7th nerve is cut totally, then there will be a contracture develop, and that side will be more prominent, and you might say that is normal and the other side is abnormal. So you have to have some better clinical examination finding. Don't go by what looks asymmetrical. Tell me findings of 7-nerve palsy.
Drooling of saliva and everything. But
So tell me, how do you test a muscle power, muscle supplied by 7 nerve?
May not
Puffing
be in
the
this
air.
particular child, but
That's right. So don't go by asymmetry. That's undergraduate thinking. Mostly right, but not always right. So examine that, right? Good. So
Muscle
there is no
power.
7 nerve palsy on this child, right? Maybe.
ask them
Yeah.
everything.
Okay, we also got a online correct answer for the same thing, absent depressor angular oris. So very good, online audience.
So now, what kind of neurometabolic disorder? I just talked to you last Thursday on basics of neurometabolic. Okay.
So how will you summarize this when you are giving your diagnosis and then answer, sir?
Someone who will say, summarize?
The most difficult thing is to summarize.
Come.
18-month-old child with
8-month-old.
8-month-old child with status epileptic.
So when you're
So
talking
not
of neurometabolic, immediately after 8 months, what should be there?
development, birth and development.
Born of a
Consanguine.
consanguineous or non-consanguineous, whatever. So here it is non-con. Okay.
Born of non-consanguineous marriage with new onset dystonic episodes, most likely an acute symptomatic etiology, without any signs of upper motor neuron involvement, and in birth and developmentally normal child, to rule out inborn errors of neurometabolic causes.
Where is the anatomy?
So it is upper in the brain, so cerebral cortex, somewhere extrapyramidal most.
But pyramidal is upper cerebral cortex or
No,
anywhere
it can
down?
be the tracts till the
There is
anterior.
7 nerve also possibly. Do you think it's a pontine lesion?
No.
Why
No,
not?
but because other things don't fit for it to be a pontine lesion. If it was that higher up the other cranial nerves, pseudobulbar palsy.
So the question is it a one point involvement of the pyramidal tracts or it is
Myelination defect or something like that.
generalized?
See, when you're
It's bilateral.
Mike.
when you're discussing neurometabolic, you start differentiating gray matter versus white matter. That's the first difference. Okay, what is this? Gray matter or white matter? Or both?
Online audience, you want to answer? Gray matter or white matter or both? Okay, go on, you also try.
See, both don't start all of a sudden. Either it starts as a gray matter and moves on to involve white matter or vice versa. Now we have a story at the onset. So both can start at the onset. Progresses, yes. White to gray, gray to white, yes. So what do you think is the onset like? Because many times they will come late to you when both are involved. But the onset is important. See, hepatobiliary, we want to know started biliary or started hepatic, then becomes hepatobiliary. Yeah. So what did it start as? White matter or gray matter?
What do you think?
So
You
dystonia
says-
it started with,
dystonia.
no? Or
Yeah.
seizure.
What? That's right.
So dystonia represents what? Basal ganglia. Basal ganglia is grey or white?
It's a grey area.
Basal ganglia are grey, but extrapyramidal fibers are white.
Okay.
So there are symptoms of both here. We have grey matter involvement. If it's a seizure, it's grey matter, right? If it is dystonia and basal ganglia involvement, it's grey matter. And you have symptoms of white matter in the form of spasticity, hypertonia and brisk reflexes, which has possibly come up later, as in we saw it just now,
So
right?
I think my impression is that as both have come up very quickly, one of them must have been subtly present earlier, and now both are progressed, and now we are seeing both together. So we need to look back and say, what was it? Was he drowsy? Was he irritable? Oh, that indicates that possibly it's a grey matter that's
first.
involved. Did he have a posture problem to begin with? Okay, then it could have been a white matter involvement. Maybe we have missed some part. The parents may not have noticed it. It's not easy to pick up early such behavior change, etc. But that may be important to pin down between grey matter and white matter to begin with. Ultimately, everything goes well. Okay, so to make it very simple to remember, the grey matter problems start rather early as compared to white matter in infancy. Okay, so something that starts at 3, 4, 5 months of age is likely to be grey matter. Something starts at 5, 6 months onwards, second half of infancy is likely to be white matter. Then there will be an overlap, etc. Like a PKU, for example, or an MSUD. All of them start at 2, 3 months with some issue of behavior or lethargy or understanding or delayed cognitive milestones, which are difficult to pick up at that time. Whereas if it's a white matter, typically say a Tay-Sachs or standoff, now you start with changes in tone, spasticity, around 5, 6 months of age or so. Okay. It's important to tell us on examination the fundus. Fundal examination is extremely important to differentiate white from grey, and therefore retinal changes would mean a grey matter involvement. So we may have to pick up that. So I think if it's an optic nerve involvement, then you know it's a white matter involvement. So some of these things are important to mention. We may not be very good at finding the fundoscopic examination finding, but in an exam you should say, sir, I tried to do a fundoscopy, but I could not make out. The examiner will say, I also can't make out, so you have got full marks. Okay, so what I mean is, but you have to say that yes. Therefore, many times in hospital you must have asked an ophthalmologist to come in and do that. It's not easy for us.
So in that summary, a little more description would be, so the points that are important are born normally, okay, initially normal developmentally, or maybe slightly delayed or slightly slow. Then the word progressive is important, because the whatever episodes are there, they have increased, and now the child's behavior also has changed and not feeding. So the word progressive should come. Progressive symptoms of both grey and white matter involvement. This should be there in your summary, which suggests a neurodegenerative disorder and most likely an inborn error of metabolism.
In every neurometabolic disorder, make a mention that peripheral nerves are normal. Okay, because some of those inborn error of metabolisms have also the peripheral neuritis as a component. Mention about skin. Some of them have eczema, skin rashes. Okay, so even if you just make a note in an exam, which ones of these are likely to be named, then I think it's a good idea. But mentioning that skin apparently is normal, peripheral nerve, there is no involvement.
Then without organomegaly, so in the same way as sir is saying, so without skin involvement, without peripheral nerve, without organo, so the moment you say one, you are ruling out one block of disorders.
Last time we said that the first part of a neurometabolic disorder was an abnormal metabolite like a poison. This is one of those. The second one was, I said that it comes as an acute crisis, which is usually energy dependent, hypoglycemic. Okay. Mitochondrial, muscle involved, heart involved. So in a neurometabolic disorder, you say heart is normal, muscles are normal, specifically. Because mitochondria typically, the muscles, the brain, okay, a liver. So, because the organs which need a lot of energy are the organs which are involved in mitochondrial disease. So that is the group. So then we can group it as one of those which are coming up fast in an early infancy, probably starting with a gray matter involvement, subtly progressing fast. Okay, this is our clinical impression. I'm sure you need a lot of tests to define correctly what the problem could be. Yes?
Show us the investigations. Okay, you want to show this video? Very good.
Is it myoclonus?
What do you think? It's an involuntary movement or a seizure?
No, he has stopped video, so he's not suddenly got unconscious. Yeah.
I think it is a seizure with intact consciousness, generalized seizure with intact consciousness. But that is very rare to happen, because if it is generalized,
No, so generalized is never with intact. It is with impaired.
Impaired, okay.
See, so the point is generalized. You means it's difficult to make out in this baby whether it's unconscious or not, but impaired is you are able to make out, and generalized will always be with impaired.
So what I thought, what we saw was that there was involuntary movement with increased tone, and they were multifocal. Sometimes it was right, then after that there was left also. The eyes were always open. There was one sensation of twitching of the face. So multifocal, involuntary movements, a different part of the body, eyes open, and after that suddenly everything stopped and a child slept, as if it was a post-ictal phenomenon. So after looking this, it looked more like a seizure rather than a spell of involuntary movements. And there were some twitchings also in between. There was.
And they did look like the tonic-clonic thing, fast component, slow component, all that. So
it was a seizure. So if this has been so earlier, that means this child has sudden onset of seizure at 8 months of age.
Okay, go on.
The patient had a repeated episodes of such dystonic movements after the starting on anti-seizure medication. The routine investigation were done, and patient got intubated in view of drop in sensorium. The neuromedicine reference were done, neuroimaging also done, and metabolic study also done. And now the patient on nasal prong with hemodynamically stable. With investigation, CBC shows HB of 6.4 with RBC of 3,500 with hematocrit 27 and total leukocyte count of 6,400 and platelets count of 2,65,000. Serum calcium was 8.6 with ionic calcium 0.9 with parathyroid hormone 12.9, with vitamin D 35.5. Magnesium level was 1.8 with lactate 18 and ammonia of 103. CRP of 1.2 and LFT and RFT were normal. ABJ presentation shows 7.44 pH with 22 PCO2 and 191 PO2 with bicarb 15.2. The Cox workup has done, which shows negative ESR 18. Amount of tests were negative. We also done lumbar puncture in which the TLC count was 1, only lymphocyte present with protein 45 and sugar of 89. We also have done random blood sugar, which shows 120 milligram per deciliter.
You want to comment on the ABG? It's bang normal?
No.
Huh? No. Very good. So what is bothering you? Normal pH is 7.35 to 7.45. So it's normal. What is bothering you?
Bicarb level 15.2 bicarb, which is
Which
acidotic, metabolic
acidotic.
acid.
But he is not acidotic.
The respiratory alkalosis is also present, so that can compensating.
Very
that.
good. So there is a possible metabolic acidosis which is being compensated by the respiratory alkalosis, right? Now you'll have to do all your calculations and see whether the bicarb value, the CO2 value, whether it's as expected, right? So good. That is to be observed. Just 7.44 looks normal, but there is a phenomenon going on underneath. Okay.
We have done MRI, brain MRI. This is a report in which the conclusion says
Last two lines.
there is a widening of bilateral sylvian fissure giving a bat wing appearance, mild to moderate generalized cerebral atrophy, more so bilateral anterior temporal lobe, and mild thinning of corpus callosum. So these imaging features are most likely related to glutaric aciduria type 1. Then they suggest a further workup of inborn error of metabolism. So we have done the...
Go back to the image. You can't enlarge it, no? Okay. Okay, go on.
Then we have done metabolic studies in which the TMS of blood and GCSMS of urine we sent for the investigation, in which they shows elevated C5DC and C5DC C2 in blood. In urine shows elevated glutaric acids. So all the above results are suggestive of glutaric acidemia type 1.
Okay, good. So you confirmed this metabolic disorder.
Yes, sir.
Okay, so from online there are some means, so we asked gray matter or white matter, somebody's answered gray matter. Good. There's a question, what was the MCV possibility of infantile tremor syndrome? So what is the MCV in this child, you know? You've not written it here. Does anyone remember the MCV? Okay, doesn't matter. Now, what about infantile tremor syndrome? Anybody wants to discuss or argue against that? What is infantile tremor syndrome?
B12 deficiency.
Very good. So it is seen in B12 deficiency. So how is this clinical picture different from that?
This looks like a seizure, long-lasting seizure, where infantile tremor syndrome is tremors with no alteration of the consciousness.
Very
at all.
good. Very good. So here it is very typically an episodic event or a paroxysmal event. Whereas in infantile tremor syndrome, it is a tremor which is present all the time. So there is no loss of sensorium. So
Pigmentation there.
and then of course pigmentation and malnutrition. This child was anthropometrically normal and all that. So those are the differences. Okay, fine. Have you read up on the treatment or anything further? What is to be done now?
There is a protein diet restriction in which the lysine and tryptophan deficient supplements we provide, along with the vitamin cofactor, riboflavin, the thiamine. So
Okay, good. What is the prognosis?
Sir, this could keep on recurring, so not a good prognosis. We have a neurodevelopmental delay with frequent seizures. There could be possibility of cognitive impairment in future.
It could also be associated with feeding difficulties and then other complications. So,
It has a poor prognosis only, these neuropathy. Even myelination will be affected in the future, so tracts won't be formed.
I think, the neurological syndrome looks to be vastly progressive. Okay, by the time we diagnose and make some diet changes, I think the damage would have been already done. The question is, how severe is the damage? Earlier the story starts, more is the damage. This has started somewhere early, but a little later part of the infancy. That is a little better. If it had started very early, then we might have missed that period. But even then, this is very fastly progressive. So we are concerned. So if you asked on an examination, you would say it's guarded, though I don't anticipate to come out with totally normal cognition. Okay, that is certain. How bad it is, one may not know. Okay, and the time will tell us. That is the right prognosis, because prognosis may not be possible to evaluate right now, because prognosis is concerned with how early or late you have diagnosed and how early or late you get a response of your intervention. Here we don't know response to our intervention. We only know it's a fairly early, not too early, but fairly early in infancy and fastly progressive. So that is little against a very good outcome, but we don't know the response to our intervention, which will add to the ultimate idea about what could be the prognosis.
And also we have to, you said eliminate those amino acids. So that is good to know, but then practically it is not easy to have those kind of nutritional substitutes, and then whether the family can afford that and all that. So it's not easy. And therefore whatever other types of proteins go in, there will be a problem.
If this child came to you a month earlier, or maybe a week earlier, could you have at least thought of any disorder? Was it possible to pick it up early, let me say? If you had to see this child at 6 months? It's your close relative's child.
Developmental delay was always there.
So there was a developmental delay, so subtle abnormalities were always there. And therefore, there was reason to suspect something, and there was nothing otherwise abnormal. So at that time, investigations A for a structural disorder of the brain and B for metabolic disorder was called for.
I think lastly, the management of all these conditions also involved a lot of non-neurological management. So especially a CP, typically a lot of other things to manage. Neurology is just one part, but the nutrition. Now this child is going to lie down at home, vitamin D. Okay, many other small little things might make the life a little better as compared to just the neurological problem. So just take a note of that. When you talk about management, it's also a lot of external. Most of these children are constipated. They may have a urinary infections coming up. They may have a swallowing problem, so they may have a pneumonias and aspirations. So you could consider management to all those levels, which are easy to make out. The specific management may be difficult, right?
In fact, most of the time what bothers the parents is these non-neurological problems. Feeding, constipation, bed sores, interaction. They have accepted the diagnosis of neurological problem. There's nothing much to be done. But these things, they bother them much more.
Good, but you did a good job. You are a junior, but you stood there in front. Very good. Very good.
Thank you so much, Dr. Shiv Prasad. You helped us to learn this case, right? Yeah, very good. Thank you. We now come to the second part of our class today. So we said every time we will discuss a small topic. So today we will discuss approach to cardiac rhythm disorders. Okay. Now, how many of you have done PALS? Your hand should be very boldly high. Okay. So almost nobody, like one or two. So that's a little sad. So you must start doing PALS as early as you can. Okay. So approach to rhythm disorders, basically, I mean broadly if you think, there are two parts to this topic. So one is the practical approach, when you will see a patient. And the second is if you have to write a theory answer, so all those syndromes and all that we can discuss some other time. But today I have borrowed this lecture which is made by our IAP ALS provider group. So I have borrowed it from them because just to serve as a framework, and we will discuss the practical approach to a child who comes to us with a rhythm disorder, right? And we'll try to keep it a little interactive. So this is okay, we'll just come to this. So basically we are going to look at rhythm groups by just a pulse rate. Okay, so what are the three groups that are possible logically? If you just have to look at pulse rate, what are the three groups that are possible?
Sinus rhythm, tachycardia and bradycardia.
Very good. So sinus rhythm is not a disturbance. So tachyarrhythmia and bradyarrhythmia. So fast pulse and slow pulse. Okay. And the third?
Missed beat.
No pulse. No pulse. Okay. So no pulse doesn't always mean asystole. So we'll come to that. Okay. So you have slow pulse, fast pulse and absent pulse. Okay. Now, what is a stable rhythm and what is an unstable rhythm? So what do you mean by unstable? Very good. So either
hemodynamic stability is there or no?
Excellent. So either the rhythm is causing hemodynamic instability just now, or suppose it's not unstable just now, but complete my sentence. But very good. It has the potential to get into trouble. Correct? So then you treat both these. And if he is totally stable and it does not have the potential to run into trouble, then you refer to your cardiologist friend, right? So those that cause circulatory instability or may deteriorate, right? Now how do you define circulatory instability? Because you want to treat him if it is causing instability just now. So what will tell you that this child is unstable?
Blood pressure.
Okay, which you should always speak last, because blood pressure goes last. You want to pick up unstable children much before blood pressure is affected.
So capillary refill time.
Excellent. So poor, how do you club all that? Poor perfusion, right? So any child who is either in compensated or hypotensive, so don't wait for hypotensive shock, even compensated shock, poor perfusion, and of course arrest, right? So now how do you go about? So which pulse do you look for, peripheral or central? Always central, right? Because peripheral pulse may be not palpable or weak or whatever for various reasons, right? Okay. Now we said slow or fast rhythm. So what is the definition of slow and what is the definition of fast? So fast is more than 220 in an infant and more than 180 in a child. And slow is always less than 60. So less than 60 is slow for any age group. Okay? Okay? Now, what is the importance of using your practical approach based on the pulse rate? So what is this equation? How do you decide cardiac output? Cardiac output is equal to heart rate into stroke volume. So now tell me, if heart rate is slow, why stroke volume, why is cardiac output affected? It's obvious, heart rate is slow, so there will be less. But why is cardiac output affected if heart rate is fast? It should be more cardiac output, no? Very good. There is less filling, so there is less stroke volume. So too fast a heart rate is also not good. Okay? So this is the reason why you get shock even with fast heart rates. Now ask yourself these three questions. So is the pulse rate slow, fast or absent? Is the perfusion compromised? That's what is going to decide whether you are going to treat or no. And then further, as soon as you decide that perfusion is compromised, what are you going to do? You are going to put the child, connect the child to a monitor. On the monitor, you are going to look at the rate. But you are also going to look at whether they are narrow complex QRS complexes or wide QRS complexes. What is the importance of this? Narrow suggests what and wide suggests what? Very good. So narrow is supraventricular, wide is ventricular. Okay? And is there a diagnostic pattern? There are some typical patterns, so you look for those patterns, right? Okay. So now tell me, what is this? Fast or slow? Fast. Now, what else do you look for in that rhythm? Narrow or wide, very good. So this is narrow. So rising from supraventricular, wherever. Supraventricular is a big area. So it's ventricle or above that. Above that could be 3-4 places that we won't go into complexities just now. What else do you want to observe on that? Very good. So regularity, how regular it is or is it variable, and what else do you want to observe? Sorry? Sinus rhythm. So means whether it's a proper QRS complex, a normal P wave followed by a normal QRS wave, or is there any abnormality, right? Okay. So now what is the difference between sinus tachycardia and a tachyarrhythmia? Okay. So sinus tachycardia, as you all know, is physiological and tachyarrhythmia is a rhythm. So now when you have a narrow complex, it could be either of the two. How will you clinically differentiate? You have a child, you looked at the pulse is very fast. So you have a tachyarrhythmia. Okay? You have some peripheral compromise of circulation. So you have perfusion compromised. Now you have decided tachyarrhythmia with perfusion compromised. You have to decide whether this tachyarrhythmia is sinus tachycardia or supraventricular. How will you decide clinically?
Based on history, whether there's anything associated, like in fever or...
Superb. So you look for the cause of sinus tachycardia in the history. Could something have given rise to sinus tachycardia? It could be high fever, it could be volume loss, vomiting, loose motions, whatever, right? So the clinical symptoms of the child in sinus tachycardia suggest the origin why this child is having a fast rhythm. And in supraventricular, the rhythm will cause some symptoms, right? So history and also the heart rate. So those limits that we set, 180 in a child and 220 in an infant, are the maximum that sinus tachycardia can go to. So if your heart rate is more than that, can you count that clinically? Can you count 200 clinically? No, almost never. So it will have to be a monitor. So clinically it's difficult beyond 140, 160 to count. But the moment you connect, you see a child with fast heart rate, poor perfusion, connect to a monitor. If monitor shows more than these values, more likely to be supraventricular. Less than this, go by the history also. Okay? So in supraventricular, it's a non-specific history of lethargy or poor feeding, which is a sequel to the rhythm disorder. Okay? What are the other differences between the two? So we said one is history, one is the rate. What else? So sinus tachycardia, where is the origin of the impulse? SA node. So you expect a normal QRS or an abnormal? Normal. So the P wave is normal in sinus tachycardia. And in supraventricular, what will happen to the P wave? It may be absent or it may be abnormal. So its morphology and configuration may be abnormal. And the last difference is that sinus tachycardia always has a variation. So when you connect your monitor, the heart rate will fluctuate. So it will be 170, 160, 180, 120, 184, that way. And in supraventricular, there is one constant figure. Okay? So it is 240 to 240 only all the time. So that is no beat to beat variability. So these are your differences between sinus and supraventricular. Everyone is clear on that? Okay. Now wide complex we said is ventricular. Okay? Fine. Now there are a very small percentage of supraventriculars which have aberrant conduction, which can give wide complex, but we won't bother with them just now. We'll see how we tackle them later. So now you have a child with very fast heart rate. You've decided perfusion is compromised. You've decided that history doesn't suggest a sinus tachycardia. So this is likely to be supraventricular. You've noticed narrow complexes, right? So you want to treat this child, correct? How will you start treating?
Vagal maneuvers. Vagal. First, hemodynamic stability.
Very good. So this child is hemodynamically unstable. So you always start with ABC. So you connected him to a monitor. You look at the airway, look at the breathing, support with oxygen. So all that you will do initially. If there's no IV line, secure an IV line, all that, right? Now you have to treat this SVT. How will you treat it?
Vagal maneuvers.
So what first is what vagal maneuvers can you do? Second is when will you, or anything, any corollary to that vagal maneuver?
So we'll do vagal maneuver only when the child is hemodynamically stable.
One, very good. And if he is unstable, when will you do? Till you are waiting for that other definitive therapy to be there. So even if you decide, okay, I want to give this definitive therapy, it will take a few seconds or a few minutes to organize that. In that interim, you may do vagal maneuver. But you don't say, अच्छा जाके वो बाजू के रेस्टोरेंट से आइस लेके आओ, तब तक we will just wait and watch. So no delay in doing a vagal maneuver, right? Which vagal maneuvers are allowed?
So ice pack over the forehead.
So infants, ice over the forehead, and older children?
Carotid massage.
Carotid massage.
Carotid massage.
Carotid massage should not be done. Okay? So what you do is Valsalva maneuver if it's a sufficiently older child. Okay? Fine. What about definitive treatment? Adenosine. Again, what is the caveat? Adenosine if? No, short half-life will come to. No, he's unstable. So you want to treat him just now. You don't want wait for your cardiologist friend. Adenosine, if IV line is available or can be achieved, you already said tachycardia with poor perfusion. If he doesn't have a IV line, you all have struggled for IV lines for 15 minutes to half an hour, no, so many times. So you can't wait for 15 minutes to half an hour for an IV line. So if you have a IV line in place or you can quickly get IV access, IV or IO, then adenosine. Otherwise,
Synchronized cardioversion.
very good. Synchronized cardioversion. So practically, if you are in a hospital setting, it may be easier that you have a defibrillator machine through which you could give synchronized cardioversion, and it may sometimes be difficult to get an IV line, right? Okay. Now, okay, how do you give adenosine? So how do you make it rapid?
With bivalve, and one side will push the adenosine and simultaneously will push NS 10 ml rapidly.
So what is the most important thing in this bivalve? Look at that picture and tell me.
Both sides should be open.
Excellent. Both sides of the bivalve have to be open. Normally when we use a bivalve, we use one, then we turn, then we use the other. So the patient end is closed and both sides are open. That is the important thing here. So that's the difference from the normal here. So you start pushing and immediately your saline, because you said it's a very short half-life. And you want to reach this adenosine to the central circulation. Doses, of course, you will remember. I don't want to repeat all that. You can always remember that, right? And he's already on a monitor. You will immediately see a change in the rhythm. Okay? So that's how you give adenosine. And if you don't have adenosine, then synchronized cardioversion. How do you do synchronized cardioversion? So on the defibrillator, you all have to do pulse now. Now the next thing you do is tomorrow morning, you all phone the IAP office, 2404-5803. Write down the number. 2404-5803. And I am allowing you to phone tomorrow morning only because the office is closed just now. Okay? And you are all going to give your names telling the office boys कि हमको पाल्स करना है, हमारा नाम वेटिंग लिस्ट में लिखो, जैसे ही पाल्स कोर्स अरेंज होएगा हमको इन्फॉर्म करो. ओके? बिकॉज वी हैव टू डू पाल्स. ओके. सो synchronized cardioversion is with a defibrillator. You put it in a synchronized mode, you select your energy 0.5 joules per kg, and then you attach the two pads and you deliver the shock, and this gets converted. We won't go into all that, right? Okay. Now we come into slow rhythms. Okay. So what is slow rhythm? Bradycardia. So anybody who has a heart rate of 59 start CPR, right? Right or wrong? Less than 60 abnormal at all ages, no? So all athletes have a heart rate less than 60. So we said less heart rate with poor perfusion. That with poor perfusion is extremely important. So if somebody has a heart rate of 50 but good perfusion, then think, is this his or her normal heart rate because he or she is an athlete, or is it a congenital complete AV block or whatever, but that doesn't need urgent treatment, right? So bradycardia with poor perfusion is what you are going to treat. What are the first 5 causes of bradycardia with poor perfusion? Second? Very good. So hypoxia, 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 hypoxia 5 times, and then all the other causes. Okay? So all your H's and T's. What are the H's and T's? Hypothermia, hypoglycemia, whatever, all those H's, and T is tension pneumothorax, cardiac tamponade, whatever, right? But all first and foremost is hypoxia, remember, with poor perfusion, bradycardia with poor perfusion. Okay? So you have 3 groups. One is originally primarily because of some cardiac cause, one is secondary to hypoxia, and the symptomatic one, right? How will you manage? You just now said, no, 5 causes are hypoxia. So how will you manage? So ABC, airway, breathing, circulation. So take care of the airway, provide supplemental oxygen, and then finally oxygen should be 100% FiO2. And also if it is poor perfusion, then you have to start with chest compressions. Okay? And then epinephrine and atropine. Doses again you remember, for want of time I am not going into the doses. Okay? Now the last bit. Suppose you find somebody pulseless, no pulse. Which, is it always asystole? I said no. So what else is a rhythm disorder which can clinically come as no pulse? Not atrial, ventricular fibrillation. So one is ventricular fibrillation. Second, there is a pulseless ventricular tachycardia. So here we said there was a wide complex tachycardia which we said was ventricular. What was the treatment? Synchronized cardioversion. Okay? So in short, if you summarize, a fast rhythm with cardiac compromise, hemodynamic compromise, if you were, once you have decided it's not sinus tachycardia, then whether it's supraventricular or ventricular, synchronized cardioversion is common to both. So you could literally quickly do synchronized cardioversion and help this child, right? And this pulseless, one is asystole, one is ventricular fibrillation, third is pulseless VTAC, ventricular tachycardia, and fourth is what is known as electromechanical dissociation. So what is electromechanical dissociation? There is a electrical activity, but it doesn't get converted into a contraction, right? So these are the 4 possible rhythms. Why do you have to differentiate between them? Very good. So 2 of them need a shock. Which 2? Pulseless VTAC and VFib. Both of them need a shock. And what do the other 2 need? Asystole and PEA, what do they need? CPR and epinephrine, right? So CPR of course everyone needs, but they need epinephrine. So your treatment is totally different. So that's why you need to differentiate between them. So when you have those automated AEDs, they decide based on this, is it a shockable or non-shockable. They don't tell you the diagnosis. And when you are there as a doctor with all this equipment, then you decide which rhythm it is and treat it accordingly, right? And of course you have to maintain oxygenation, you have to do your airway, breathing, circulation all the time, and you have to keep doing CPR, right? Now what pulse rate would result from this rhythm? So what is this rhythm? So there is no rhythm only, na? It is all haphazard. So it's as good as VFib, ventricular fibrillation. So no pulse. And what are the priorities? What will you do? If you say shock, you will fail in exam. you have to say ABC. So you have to say ABC, or to start with CPR, maintain airway, give breathing, oxygen, and then defibrillate. In that order you have to say. Otherwise you will fail in exam, okay? Okay. I have not gone into all the drugs like amiodarone and all that, procainamide, all those are other options, but this is the basic, very broad outline of a practical approach to rhythm disorders when you see a patient in front of you. Okay? I think rest is, yeah, okay? Any questions on this? So now all of you will do PALS, where this same thing will be discussed in much more detail, and you will be also taught about how to give synchronized cardioversion and how to give defibrillation. Right? Okay. Thank you. Thank you to all our online friends. We meet next Thursday at 6 p.m.